Today, I will talk about one of the most important drugs used against breast cancer, Tamoxifen. And the question is whether we can improve the treatment we offer today even further, because we need to know that we have really good results from breast cancer treatment. But can we perhaps improve this even further by taking more individual concern in the choice of length of treatment and dose, perhaps. So this is more the introduction to what I'm going to talk about today. We have done some research together with and the core team around this research is Sara Margolin and Linda Thorén, who are breast cancer oncology experts at the Södersjukhuset, where myself, Erik Eliasson, and Jonathan Lind, we work as clinical pharmacologists at Huddinge in collaboration then in this team. Linda is the PhD student here, and Sara is her main supervisor, and myself together with Jonathan is the co-supervisor to Linda in this respect. We also collaborate here at Karolinska with the two leading names in breast cancer, of course, Per Hall from the Department of Medical Epidemiology and Biostatistics, and Jonas Berg at Radiumhemmet, Oncology Pathology. So, the facts to begin with, in summary, breast cancer is by far the most common cancer in women, and it corresponds to 30% of all cancers. So in Sweden, we have more than 100,000 women who have received this diagnosis and perhaps are still on ongoing treatment or received this diagnosis earlier on during their life. Unfortunately, this is then a common disease, and it's still a significant mortality in breast cancer. So we have almost 1,500 women every year who will die from breast cancer, and that's second to the most common cause of cancer-related death in women, which is lung cancer. But of course, as you know, breast cancer affects also younger patients. Up to a quarter of all patients are pre-menopausal. It looks good when it comes to, though, the treatment options we offer. So there's an increasing incidence of breast cancer in the Nordic countries. We are not really sure about the reason for this, but to some extent it relates to a better diagnostics. But we see a drop in mortality. It's going gradually down. And today the 5 years of survival rate with this diagnosis is 90%. So that's really good when it comes to cancer treatment. But there is some increased concerns that the risk is not really over after 5 years treatment. We need to be concerned about long-term relapses after this first period of treatment. And tamoxifen is usually used then for 5 years as an adjuvant, a follow-up drug to surgery. So what can we do to improve this treatment even further? Well, I had this question about individualized drug treatment in my title, but perhaps to some extent, it's already here. Because in breast cancer, we do consider important characteristics of the tumor size and in infiltration, and also the malignant cells themselves. What do they express in when it comes to targets for therapy? And stage of the disease, as in any cancer, is really important for the prognosis and also the choice of treatment here. So many patients are then subject to adjuvant drug treatment. That means after removal of surgery, patients are treated to prevent the relapse in disease. So even after successful surgery, we would like to lower the risk for micro metastasis growing and then with the relapse in the disease. So that's really the point of the adjuvant drug treatment, to prevent a new tumor or a relapse of the original tumor. And in this respect, also age and menopausal status are already today taken into consideration on how to best treat these patients. So to this extent, at the group level, we do have an individualized care of patients. When it comes to daily dose, length of treatment, what is the right length of treatment? Can we monitor the disease when it comes to laboratory tests? Or should we measure how much active drug we have in blood? And how should we handle other drugs used by the same patient to prevent that these other drugs may disturb the action of tamoxifen or the adjuvant drug? That's the type of concerns we usually take into consideration when we mean individualization of drug treatment. And could we perhaps also find some kind of individual predictors who will suffer from side reactions to this treatment? Okay, tamoxifen then, perhaps the most important drug in the treatment of breast cancer. It's been used during several decades then to prevent relapse. And also, well, originally it was actually used to treat only advanced breast cancer, but now it's even used for prevention to some extent in high-risk individuals. It's a non-steroidal, in its structure, selective estrogen receptor modulator. So, you know, estrogen receptors or all sex hormone receptors are then binding to steroids, sex steroids, but this will then be able to bind to the receptor without the identical structure as the hormones. But it will influence on the signaling. It will disturb the estrogen signaling by binding to the receptor. And that means a lot. It means that we can actually even reduce breast tissue proliferation in general, but also of the malignant cells. So it will have an impact on the survival and proliferation of ER, estrogen receptor positive malignant cells. And that's quite common with ER positive cells. It's found in the great majority of breast cancer cases. So up to 85% of all breast cancers do express the estrogen receptor in sufficient amounts for these patients to candidate for endocrine treatment, as we call it. So tamoxifen is the main adjuvant drug treatment of breast cancer today. It works both in women before the menopause and also after the menopause. But for post-menopausal patients, we today have a pharmaceutical alternative which is at least as good as tamoxifen, and they are called aromatase inhibitors. But for younger patients, that's really not an option. We need to modulate the receptor action in itself. So, a common cancer, we have many patients being treated with tamoxifen. It's actually more than 17,000 patients last year being on tamoxifen prescription. And what is known from international studies, and I would like to point out this, the work from an Oxford-based but still worldwide collaboration, the Early Breast Cancer Trialists Collaborative Group. They review all the data from all clinical trials in breast cancer, have really good overview and of all results generated in this research. So they have they publish a lot and a good source of information if you would like to dig deeper into this. And what they then conclude is that tamoxifen markedly lowers the risk of recurrence of the disease. So 40% relative risk reduction is quite much, since we know that the risk is quite high from the start. And also mortality goes down. That's really well established. There's 30% relative risk reduction in breast cancer-related mortality. So an important drug for sure. It was introduced in the 80s, and originally it was used for 1 year or 2 years, but now it's clear that we need a long treatment with tamoxifen. We need up to 5 years at least, and then on this standard dose I was mentioning, the 20 milligrams per day. That's the same dose for all women, and that's perhaps something we could come back to. And having a chronic treatment like this, a chronic treatment of cancer, compliance will be an issue. Will patients go on to take this drug every day for 5 years? No, we do have a problem here with I shouldn't say poor, but it's still many patients who stop treatment, a dropout rate of around 30%. So that's quite much. So many patients do not get this efficient protection by tamoxifen. Okay, what is known about the tamoxifen action then? Well, it's well known now that tamoxifen itself is a prodrug. It's not really the main drug that is active on the receptor. It needs bioactivation by metabolism in the liver mainly. So you generate by this CYP enzyme 2 active metabolites, and endoxifen is the most is the dominant one when it comes to concentrations in blood. So you need from this prodrug a bioactivation by metabolism by a specific enzyme in the liver called CYP2D6. You might have heard from this enzyme before because it's known for, and it's been a lot of research on this both here at campus and in Huddinge, the polymorphic behavior of this CYP2D6 enzyme. People differ very much in how much 2D6 they express in the liver. So that could be a problem if you're dependent on drugs that will be cleared from the body by this enzyme. So then if you're really low in your activity, you will just accumulate the drug. But in this case, you will be dependent on the enzyme because you need the bioactivation. Fortunately, though, we can get a good idea about the individual capacity by genotyping the patients, and it's clear that we have essentially in the population covering almost a linear expression of how much enzyme you express. But there are patients who actually lack the enzyme itself. It's almost corresponding to 10% of the population who lack the enzyme required for a good bioactivation, and that's a concern. Some patients have the genetic predisposition to metabolize stronger than average or normal, if we could say that. But anyway, the thing is, we can understand from genetics how much activity an individual patient has when it comes to CYP2D6. So this was something we'd like to test when it comes to the outcome of tamoxifen treatment, that we believe that the genotype of this enzyme was a relevance to the outcome of treatment. So in order to do that, we need to use, of course, patient material and patient data. A retrospective approach to this research. We would need to know in a cohort how things really turned out, were they successfully treated or not. And we also needed a population of patients that were well defined when it comes to tamoxifen use, that this was the only or the leading adjuvant drug for these patients. And we also needed to make sure that they had at least used the drug for a year or so, because we know that that's the minimal time we need to use tamoxifen to get some effect of it, some protective effect. We were also concerned that some of the other drugs used by the same patients might disturb the action of tamoxifen, so we needed to take a closer look into medical records to look for interacting drugs. And more of a secondary issue we had was, does it differ between menopausal and premenopausal younger women to postmenopausal patients in the possible importance of this enzyme or the genotype. So we used the material Sara had collected from Södersjukhuset and Huddinge, and had 393 patients on endocrine treatment, and only it's called endocrine treatment if you use this estrogen receptor approach. And we needed to make sure from the medical records that they had used the drug for at least a year. So we had 313 cases observed for more than 11 years in median. That's a long time, really. It's a long follow-up. So it would be possible perhaps to see the possible impact of the CYP26 polymorphism. And what we measured was the recurrence in breast cancer or mortality in breast cancer. And this is the way it looks if you just compare the Kaplan-Meier survival rate in two different groups. We split the material in two different groups, the ones having a lower than 50% activity and the ones having more than 50% activity. So you could say the normal ones compared to the ones being a bit slower or even absent in their bioactivation. What we could find in this multivariable analysis was indeed that both for recurrence and mortality, CYP26 slower patients had a poorer outcome from their adjuvant treatment. But here you also see the idea of how otherwise good the protection is. But it's not as good protection if you are slow in CYP26, it appears. We could even get further support for this if we use the genotype to try to, on a more high resolution level, understand if they are absent or really low in their CYP26, or if they might even be more rapid than usual. And then you can see that the pattern here looks quite convincing according to our hypothesis, then that the ones being really slow, the blue ones, you have a poorer prognosis than the intermediate ones in green, compared to the normals, and even and the best prognosis seems to be from the ones who have a rapid metabolism of tamoxifen. And that the same pattern is true for mortality. But this was not new data in the field. Somehow it's been controversial, so some people have already looked upon this, but what we think was a new finding in our material was that it differed between premenopausal patients and postmenopausal patients. So the premenopausal women were more dependent on CYP26, it seems, because what happens there is that the effect of being slow is stronger than the average population. So if you compare this one in premenopausal women compared to postmenopausal women, you don't see the effect here in elderly women, but you see the dependence on CYP26 in the younger patients. And that seems probably related to that if you have your ovaries intact with producing estrogen, of course it seems logical that you are more dependent on the inhibition of tamoxifen. So the tamoxifen bioactivation is more important in that case. That's the major conclusions from this study, is that we did see a significant impact of the 2D6 polymorphism in the entire material, but it seems like most of it came from the premenopausal group of patients. But still, this was not our main hypothesis. This was more a subgroup analysis, and we need to validate this, so we are not really... this is just an original finding that needs to be reproduced in a larger material. So what we have started now, it's an ongoing study together with Jonas Berg, is essentially a similar approach. It's a retrospective approach. We look at women who started on adjuvant tamoxifen between the years 2006 and 2013, and have some focus to look closer to premenopausal patients. So 500 out of 1250, that's not really corresponding to, it's not representative for the population. It's a higher frequency of premenopausal, but it's needed for us to be more sure on that this will be a fair analysis, whether or not it's true that premenopausal are more dependent on SUP-26 than the others. But another good thing about this study will be that we have something called the Prescribed Drug Register. It's Socialstyrelsen, the Board of Health and Welfare in Sweden, who have collected all dispensations of drugs at Swedish pharmacies in a register. It started in 2005, so in late 2005, so we will be able to track if the individual patients really have collected their tamoxifen, and that will give definitely one of the best ways to understand if patients are on tamoxifen or not. Of course, there's not final evidence that they actually take it, but if year after year you go and collect it in the pharmacy, it seems likely that you are compliant to treatment. So this is actually a very good register if you're interested in drug-related research. You could see what's been collected at the pharmacies. Another good thing about it is that we will be able from this register understand if there are significant drug-drug interactions in play here. So we could more exactly exclude or take into consideration whether there are other drugs used by the same patients that would be of relevance to tamoxifen. And this is just an illustration on Läkemedelsregistret. It's a very good source. Okay, so we did an interim analysis of this population, the new one, and understood in November last year that we really see a good treatment effect here. We have quite few events, and we need we had dimensioning of the study based on the number of events, so we will need to wait until we have enough of events to be able to compare 2-6 status with the outcome. So it's to be a PhD student in this project, you need to show some patience then to understand the true comparison that will be made in 2 years' time. So it's important then for the conclusions that we have enough relapses and also mortality data. What's also added in this new study is that we will, in the patients who are still on treatment, we can measure the active metabolites. And that's quite good, because that means that we will see the relevance of the genotype to active metabolite generation, and we will see the relationship between these active metabolites and the outcome. And what is shown here to the left is that we have individual genotype and the predicted activity you have from in SUP-26 and how much endoxifen we have on the y-axis. So it fits with that for sure. We have quite low levels of endoxifen in the ones lacking SUP-26 activity. But what you also can see is that even the ones with a normal, so to speak, genotype, they have more endoxifen, but it's quite variable between individuals. It's not like that from the same dose, patients differ quite much in how much metabolite they generate. But the exception would be the ones being without the enzyme. They all of them have low levels. The low levels are still there, and it's been shown that you can actually increase those active metabolite levels if you increase the dose. So that would be perhaps the way to compensate for bad bioactivation, that to some extent you still have some generation of metabolites through other pathways, and if you increase the dose, you will perhaps get enough endoxifen and a sufficient effect as an adjuvant treatment. But this needs to be, of course, studied more closely. The other thing we will include into this study is the collaboration with Per Hall, who has identified the breast density measurements you could actually perform on the standard mammography. The breast density is a really strong risk factor for breast cancer. So the if you have a high enough breast density in the gland, you will have an impact on your individual risk. So that's really an interesting area in itself, that you could use the standard screening with mammography to identify patients at higher risk of breast cancer. But here we will take a look from another angle, because patients will also be followed by mammography, and the contralateral breast response to treatment could actually be a very good indicator of a biomarker of tamoxifen treatment, that you do see a reduced density. The white area here is reduced by tamoxifen. So that's clearly of relevance, because it offers something extra to the clinician. They can actually see not only that the drug is taken, but to what extent the patient actually responds to treatment in the breast gland. But that's perhaps a step into the future, but what we will know more about, what we can say already, is that tamoxifen will stay as a really important, an essential drug, as some really worldwide drugs have been classified, an essential drug that saves many lives. But the 5-year treatment is under debate, because we know there is a lifetime risk, it looks like. So perhaps more patients, not only the high-risk patients, will be encouraged or instructed or recommended to go on for longer, because it has an impact on the risk. One idea would be to perhaps go into primary prevention. It's already an approved indication in America that high-risk individuals could use tamoxifen as primary prevention. But in Sweden, it's still not an approved, in Europe, an approved indication, but it's still on the way to be recommended for high-risk cases, that if we identify women with a high risk, perhaps, without the diagnosis, you could still utilize tamoxifen as a way to lower your individual risk. But I can come back to that. What we then suggest could be an option in the future, that would be to genotype patients to see what CYP2D6 genotype they are, or in combination with perhaps metabolite measurements, we could understand how much tamoxifen active metabolites they generate, which would have an impact on the treatment response. The genotype could also be used to differentiate between individuals to what they should use as a starting dose. If you're expected to generate very little of active metabolites, you might need a higher starting dose. And but that's really something that needs to be evaluated in clinical safety trials as well. So if we go to a possible scenario where genotyping and monitoring with other measures like the breast density reduction, it could look like this, that we do have a standard arm of treatment that looks very much like today's treatment. This standard monitoring could of course utilize also from this type of early response biomarker, like the radiology, the breast cancer density measurements. But from the start, you need not only to type the tumor to see what type of targets they express in receptors for different treatments, because that leads to this choice of drugs, but you might also consider then genotyping of patients to understand what they should have as a starting dose of the adjuvant treatment. And if you then are not, I shouldn't use abnormal because it's just a spectrum of different activity. If you're not the standard patient, you could be subject to more intense monitoring. That's probably a good way in general for drug treatment, that we identify risk patients for drug treatment, and they should be taken a closer look at during the early phases of treatment. Where we could measure drug levels, the metabolite levels, we could follow the early response biomarkers, and then if something doesn't look good, we could make the individual dose adjustments. So that's not only a scenario for tamoxifen. It could be used, or it is actually used already, but try to understand that patients are different. They need an individual consideration of drug and dose as well. I would like to just show you this address to the treatment guidelines for breast cancer, for anyone of you who would like to take a closer look. It's a really good document. It summarizes all different aspects of breast cancer treatment. And it's been updated very recently in January, and it's both at the national level and national agreement, but with this important regional implementations as well. So different regions of Sweden are different in their resources. Right, I think that's all. So thanks for listening, and any questions would be appreciated. Thank you. Thank you.